Today we're going to talk, actually I can't tell you because that, ruins the case study. We're going to talk about a patient, Mr. J.S. I don't know, how do you people pick out letters? I just like hit 2 on my keyboard and that's the name. Anyway, Mr. J.S., okay? So, Mr. J.S., he's post-op day 3 after his XLAP. I have no idea why they did an XLAP. I don't really care. He came to ICU, intubated post-op because he had hypotension and tachycardia. So it's now day 3. You assess him. His heart rate is 95. Blood pressure is 105/70. He's not on any pressors anymore. His temp is fine. He's on the vent, SIMV volume control, FiO2 40, PEEP 5. Rate is set at 14. He's breathing 14. His tidal volume's 420. His peak pressures, I didn't write, but they're 21. You have a blood gas pH of 7.44, CO2 35, bicarb 23, PO2 of 95. Okay, who wants to interpret that blood gas for me? It's normal, perfect. Pick the easy questions. And he's sedated on midazolam, and his GCS is 7. What should we do with this guy? Continue rounds, go see the next patient. Done, he's fine. So he's breathing at 14, it's set at 14. Someone wants to hold sedation first. I like the sedation, I like the pressure support idea, I like the sedation idea first. So we are going on vacation. You guys heard of a sedation vacation? Yes? Sedation vacation have gotten a lot of attention over the years for ICU because they are good for patients. So holding sedation daily on ICU patients allows for assessment of neurostatus. You neuro guys like that. Allows us to see if they're ready to extubate. My favorite is when we go around on a patient and they're sedated, and then we say, can we extubate? And they say, no, their GCS is 5. Well, why is their GCS 5? Because they're sedated. And why are they sedated? So they don't pull the tube out. Do you see how this circle goes? Yes? So sedation vacation, what that means is usually in the morning, 6, 7 a.m., we turn off sedation or we hold sedation and we see what happens. It also decreases the number of vent days because if the patient doesn't need to be, you can assess quickly daily, do they need ventilation or do they not? Which can reduce length of stay. The sooner you get someone off a vent, the less rate of VAP you have. We haven't talked a whole lot about VAP. What is VAP? VAP? Exactly, ventilator-associated pneumonia. Ventilator-associated pneumonia is bad, okay? The more we can avoid it, the better. And if you're not on a ventilator, can you get ventilator-associated pneumonia? No. So let's avoid VAP and get people off the vent. Sawa? So this one is also interesting because we don't think about this much, but it also reduces ICU PTSD, post-traumatic stress disorder. And we don't often talk about the psycho effects of being in ICU, but it can make people a little bit crazy. My boss's husband at one point was in the ICU, and hallucinations continued for weeks after all the sedation, everything he was going through. So ICU psychosis, ICU PTSD is a thing. So ideally we should hold sedation on all patients unless contraindicated. So contraindications would be if they're on super high dose pressors and are just unstable. Are we gonna extubate this guy today? No, right? If we're, borderline almost doing CPR, let's just not rock the boat. Let's let them be. If they are on super high PEEPs or FiO2, we might not want to wake them up. If someone has ARDS, we might need to give them more sedation to keep them oxygenating. So if it's a patient that you're having to paralyze to keep their SATs up, should we hold their sedation in the morning? No. The other one is a difficult or an unstable airway. So an example for those of you on medicine is we had this patient with spina bifida who was very difficult to intubate, he was decreased GCS, but difficult to secure the tube, difficult to keep it in. He is one that I would not wean his sedation until I was quite sure I was going to extubate him, because I wouldn't want him moving around and taking that tube out and putting himself at risk. Someone who, if they self-extubate, will die, which sounds crazy. But these patients on high PEEPs, 14, 16, 18, 20, if that tube comes out, they can instantly code. I had an OB patient, she was gravid, 30-ish weeks, I think, intubated, PEEP of 16, she was doing okay. She woke up with a start, pulled out her tube. They're trying to bag her, her SATs dropped, she coded. Gone. Baby, we tried to get her out, but also gone. That is a patient I wish we had paralyzed and not weaned sedation, right? So, but for most patients, sedation vacation is a very appropriate thing to do to see what's going on, right? So this guy, Mr. JS, we hold his sedation. They call you and say he's agitated. What should you do? Good, talk to the patient. You wake up in a strange place, you're tied down, you have a tube in every orifice in your body. Are you going to be agitated? Who's going to lay there calmly and say, oh, I love having an endotracheal tube and an NG tube and not Foley, and you know, my hands are tied and there's something itchy in my neck, and everyone will be agitated, yes? So talk to your patient. It's okay, Mr. JS. You are in the hospital. There is a tube in your throat to help your breathing. You have a catheter. Relax. Short call is fine, right? Very stressful if you have to go and you're waiting for someone to take you to the show, right? No. To just explain those things. Often they will calm down. However, he's been on midazolam. So when they wake up from midazolam, are their heads perfectly clear? No. 5 minutes, he's going to be agitated again, right? Because he forgot what you just told him. So what do you need to do? Tell him again. Okay, so as we're telling him, you're fine, tulia buana, hapa ni hospitali, tunakusaidia, tube katika ko, inasaidia pumua yako, right? What should we do on the vent? He's now awake. What did you want to do earlier? Pressure support, right? When he was sedated and breathing at a rate of 14, he may have been okay on pressure support, but now we want to do it formally, okay, for sure. And so, like I said, the literature likes to talk about sedation vacation. They also talk about spontaneous breathing trials, okay? SBT, and this SBT can take various forms. And I go over this just because you will read. If you're reading about ventilation, it'll talk about, have you done your daily SBT? And what are you talking about? We do this. So one form is T-piece. What a T-piece is literally oxygen tubing connected to a connector that sits on the endotracheal tube that's open on the other side. So you're giving your patient oxygen. Are you giving them PEEP? Nope. Are you giving them pressure support? No, you're just providing them with oxygen. It's almost like taking a simple mask and laying it over the end of their endotracheal tube. So it is a way of testing, is the patient able to breathe on their own, okay? However, what do you think is easier, breathing through a T-piece or breathing extubated? Extubated, right? That T-piece, you have an endotracheal tube from here all the way here, and it's narrow, right? 7.5 millimeters is the internal diameter that you're breathing through. So you have a lot of resistance. So it is more work for the patient to breathe through a T-piece than it is for them to breathe caquaida. So you're going to expect some tachypnea or whatnot. So we don't often use T-pieces anymore. We used to use them often because our vents didn't do pressure support well. Some people say, let's do CPAP. CPAP says, just set one pressure. We still give them some PEEP, right? But when they go to breathe, they don't get any pressure support. And so again, they are having to work harder than they will when they are extubated. Sawa? So then we get to our last one, CPAP plus pressure support. And we talked about pressure support a few weeks ago. Pressure support likes to help, okay? So what pressure support does is it gives a boost of pressure every time they breathe in. So it allows them to breathe on their own, set their own rate. They still have their CPAP, or the PEEP. They still have FiO2, but every time they breathe in, they get a boost of pressure to help overcome the resistance of the tube. Okay? If the pressure support is high, then the machine's doing more work. Okay? If the pressure support is low, the patient's doing more work. So your best pressure support for extubation is 5 to 8. Okay? If someone's on a pressure support of 20, they're not ready to be extubated. So they are on pressure support mode, but they're not ready to be extubated. So of these things, often what happens is we leave the patient for an hour, and then we say, Labda, let's wait another hour. I'm not sure, okay? We do this all the time. If they are on TPs or CPAP, what do you expect? That next hour, they have already been working hard to breathe for an hour, right? So they're going to expect them to tire out, okay? Because they're working harder than they would when they're extubated. So if you're doing TPs or CPAP without pressure support, don't do it for more than an hour. After an hour, either you say, yes, they're ready to be extubated, or no, let's leave them on the vent. Don't torture them by leaving them on TPs milele or pressure or CPAP milele. On pressure support, we are supporting them, right? So you can leave them on pressure support milele. Sawa? All right. So we take our guy, we place him on a pressure support of 6, PEEP of 5, FiO2 of 35. It's been 45 minutes. His respiratory rate is 28. His tidal volume is 340. His SATS is 96. He looks okay. Can we extubate him? The respiratory rate's gone up. We were 14, it's now 28. What else changed? Right, the tidal volume's now 340. So can we extubate him? What we're not liking, his volumes are a little bit low, and his rate is a little bit fast, right? The question is it too small and is it too fast? How do you know? We need an RSBI, exactly. So RSBI is to answer that question of when you have someone who's got a rate of 28 and a tidal volume of 340 that you're kind of, are we breathing? Because if someone gets tired, they're going to take less volume and breathe faster, okay? So RSBI is an index that reflects if the patient is able to ventilate with minimal support. So you only calculate an RSBI in pressure support mode, okay? You can do the math in AC or SIMV, but it is an absolutely useless number and you have wasted your time. So don't. So the formula is your average respiratory rate divided by your average tidal volume in liters, okay? So for Mr. JS, his rate was 28 divided by 0.34, sawa? And that equals 83. If this number is less than 105, then they are okay. They should not be getting fatigued, okay? If it is greater than 105, then the patient's breathing too rapid and too shallow, and they are going to tire, okay? So he's kind of heavy, right? His RSBI is 83 with these values. Is it 83? Yeah. So compare it to, right now, what do you think your respiratory rate is? Any guesses? What's a normal respiratory rate for an adult? 14, okay? Normal tidal volume? 400, right? 14 divided by 0.4 is 35, okay? So I just give you that to see how the variation you can see in RSBI. Sawa? So can we extubate Mr. JS? Or do you have some more questions? We have a yes, we can. We have a confident, let's take that tube out. Okay, good. Any other thoughts? How awake is he? What other questions do we want to ask? What was the reason for intubation? Any other questions? Okay, so questions. Was the reason for, that's not supposed to say extubation, was the reason for intubation resolved? Right? So why was this guy intubated? He came out of theater, he was a little bit hypotensive, a little tachycardic, we wanted to watch him, right? Is that better? Yeah, okay, check mark. Reason for intubation resolved. Is he off pressors or only low dose? Okay. Yes. The reason for this one is you don't want to extubate someone who has a high potential of coding. Because if you're at a CPR and they're already intubated, is that a much easier CPR? Yes. So if your patient has a high likelihood of needing CPR, don't extubate them. Sawa? And so if they're on super high pressors, you might just want to leave them. Do they have a GCS greater than 8? Okay? Are they following commands? And that goes with this one. Are they able to protect their own airway? Right? Ventilation, when we intubate them, we're protecting their airway, we're taking over their functions of their upper airway. So when we take that tube out, are they going to be able to do that, yes or no? All right, then tolerate spontaneous breathing trial on low pressure support with an RSBI less than 105 for about an hour. Did he do that? I told you it was 45 minutes, so we check another 15 and his RSBI is 80. And his heart rate and blood pressure remain stable. There are some patients who, as soon as you put, we had the guy that stayed in ICU bed 6 forever, the surgical patient who kept putting chest tubes in and neuro gave him up. That one, he would look okay on assist control mode, and then we put him on pressure support, and he'd get super agitated every single time. And then we put another chest tube in, and he got better. So don't say, oh, he's fine, he's just tachycardic at 150, even though 3 hours ago his heart rate was 80. If there's other things, make sure you look at other things. So, is Mr. JS ready to be extubated? Yes, right? So you've asked all of these questions now, right? Yes, so we need to prepare for extubation. How do we prepare for extubation? What do we need to do? Tell the nurse to extubate? Sure, but the nurse says, I just got here from dental ward. How do I extubate? She's very familiar with the mouth. She knows that all the teeth are fine and clean. It's good. But what do we need to do to extubate? So preparation. As you're getting ready, double check he is ready. I've gone to extubate someone before, and then their GCS was 3. It was 10, 15 minutes ago. Now it's 3. Am I going to take this tube out? No, right? So as you're preparing, confirm. Ensure he has been NPO for about 4 to 6 hours, right? Why? Why do we want him to be NPO? Aspiration. We don't want him vomiting while we take the tube out, or if we have to re-intubate him, right? If there are times when we forget, some places you can also say just suck out the NG tube, okay? So ensure access to intubation equipment, and we have a functioning IV. I sometimes laugh when we set up for an extubation here, even today. I said, let's set up for an extubation, and they grabbed an endotracheal tube, they grabbed the laryngoscope, they grabbed the blade, they grabbed the stylet, we had our IV working, and they put it all by the bedside, but they did not grab an ambu bag. If your patient deteriorates, what are you going to grab first? Your laryngoscope or your ambu bag? Ambu bag, right? So have the ambu bag ready to go. Okay, I don't necessarily want the laryngoscope and the tube on the bedside, okay? Because I know, as long as we know where it is, but I really need an ambu bag and a mask. Ensure someone who can intubate is close by, okay? That might be you. When I extubate, I know I am close by. But it might not be you. And if it's someone, if it's someone you know is a difficult airway, you might want someone else around. If you're telling the nurses, hey, go ahead and extubate, and then you're going home for lunch and you live up at the CTC, if there's trouble, at least you get to run downhill from the CTC. I have to run uphill from my house, right? So someone in proximity, right? As a medicine team rounding, as surgery and theater, are they able to come out, right? So do all that to prepare. All right. Then the procedure. Sit the patient up nice and high and explain what's going on. This part, the explaining part, if they are fighting you, don't spend time to be like, it's okay, Buana, just relax. I'm going to tell you what we're going to do as he's trying to punch you in the head. If he's trying to punch you in the head, skip the explain part. Suction the endotracheal tube until there's no more secretions. This is our last chance. Once they are extubated, we cannot suction them anymore. So make sure they are clear. Suction the mouth and the oropharynx. In their trachea, they have this endotracheal tube with a cuff on it. What is the function on the cuff of the endotracheal tube? No, it is not to keep it from dislodging. Don't worry, everybody says that, but you're wrong. It is not like a Foley, which is a giant open balloon floating around in the bladder, I think, again, below the diaphragm. I'm not really sure what happens below the diaphragm. But you've got a big balloon over a small little hole, right? Is that how the Foley in the bladder works? I'm looking at the OB side because it's closer to their work. No, right? You have a tube with a balloon in a slippery... So don't count on your cuff to keep your tube in. It won't. So what is your purpose of your cuff? Right, prevent air from getting out. Create a closed system for ventilation, right? I am pushing air into the lungs, and if the air can escape out the side of the tube, it will. So that's one purpose. What's another one? Prevent aspirations, right? So it is reasonable to think we have a puddle, a gross puddle of oral secretion sitting on top of that balloon. Yes? Does that make sense? So before we extubate, let's suction that puddle up as much as we can. So be a little bit aggressive with that yonker. While you're suctioning with that yonker, you want to confirm that you have a cuff leak, okay? Or not a cuff leak, that the patient has a gag. Right? If you're going back there with the yonker and they're just looking there and they're not doing anything, is their gag reflex working well? What does that say to their ability to protect their airway once they're extubated? Heebie-heebie, right? So assess it at the same time. Then you want to set up your oxygen. Does everyone we extubate need to go on a non-rebreather? No. You know your FiO2 before you extubate. We often extubate off of 30 or 40%, so a simple mask or even a nasal cannula can be fine. Then you want to drop that cuff, and you want to ensure that you hear air escaping around it. All right? If you don't hear air escaping around your cuff, what does that mean? You may have edema, right? So if you've got your tube into your cuff, and you drop that cuff and it's still a tight seal, either you put too big of a tube in, which I did to the kid last week, and so I didn't have a leak, but I thought I knew I put this tube in, and I knew it was big, so let's just take it out and see what happens, right? Or, alrighty. Hello. So, if there's no leak, possibly you have edema, right? Or possibly your tube was too big. You don't know. So you have to decide what you're going to do. You can say, like I did the other day with my kid, you know what, I'm pretty sure this tube is too big because I put it in, and when it went in, it was kind of tight, but at that point, I just wanted the tube to be in. And take it out and deal with the possible risks. Or you can say, I'm going to wait a day. If you're waiting a day, you can give the patient steroids to reduce the swelling, okay? So, but most patients will have a cuff leak. So you drop the cuff, you hear gurgle, 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 they're aspirating all that stuff on top of the cuff. It's super uncomfortable at this point. You can hear, when you drop the cuff, you can hear the air full of bubbles. It's lovely sounding. And the patient usually is coughing quite a bit. So at this point, you want to move quickly and get that tube out. So untie the ties, you have a leak, and quickly pull out that tube during inspiration. When you inhale, you're opening your vocal cords, yes? So that's when you want to take the tube out. I know it sounds like you should be coughing the tube out, but you actually open and close your cords during coughing. So get the patient, if they're listening, to breathe in, pull that tube out, suction their mouth, encourage them to cough, and place patient on oxygen and assess. What should we assess the patient for immediately after extubation? What should we look at? Saturations? What else? So SpO2, oxygen saturation, same thing. What else? For stridor, good. How do we listen for stridor? You're right, you want to listen on the neck, okay? And we'll talk more about that in a minute. What else do we want to look at? Are they coughing? What else? All right, first you want to just look at their breathing. Often the pulse ox falls off during extubation, right? So look, you take out that tube, but just look at their breathing. Are they working hard? Do they have indrawing? Are they struggling? Or did they decide to stop breathing on you because they were being annoying? They shouldn't. If you did your test well, if they've been on pressure support for an hour, they should know how to breathe. But just double check, okay? Then, are they able to cough, vocalize, and swallow? That's all looking at airway things. I'm more concerned about their airway than their breathing. Because their breathing, I checked on pressure support before I took the tube out, yes? But the tube, now it's out, and I need to make sure their upper airway is okay. Look at their vitals, and then auscultate, including the neck, for stridor. So stridor is a high-pitched wheeze, loudest at the neck during inspiration. And it indicates narrowing of the upper airway. So immediately, as you notice this stridor, so this kid who I intubated with the too big of tube, I extubated, he had increased work of breathing, he had some stridor, which is not uncommon in kids. We immediately nebulized with 5 milligrams of adrenaline. Straight adrenaline, don't dilute, 5 vials like you would give, so the equivalent of, 20 minutes of CPR, right? Because you're nebulizing it, you're wasting a lot of it. If they are under 10 kilos, you can make it 2.5 milligrams. Again, no need to dilute. Nebulize it immediately. What does epinephrine do to the blood vessels? Vasoconstrict, so it's immediately going to lessen your swelling, okay? So, as you're nebulizing, you want to listen to the lungs and see, do I hear air coming in and out? Because if I don't, I'm getting worried, okay? At that point, if I'm not hearing air going in and out, I'm going to prepare to reintubate. And if they don't improve with epinephrine and they're in distress, I'm not so worried about their saturations. Patients can saturate well and not ventilate well, okay? So if they're saturating well, but you see them, now I'm going to make myself choke, right? That patient is in trouble. If they're still a little bit wheezy, but they're moving air and you can hear some air entry and they're calming down, then you can watch them and again give them steroids, okay? You may have to repeat the dose of epi. Is there any purpose in nebulizing salbutamol? No. Where does salbutamol work? What does it do? It relaxes smooth muscles. Any smooth muscles in our upper airway? Nope. So don't waste time nebulizing salbutamol. Just go direct to adrenaline. All right, so this is basics for weaning of our normal patients. However, we have patients who are not normal, who need something called a long-term wean. So they've been on the vent for a week or two. You put them on pressure support in the morning, you give them a pressure support of 6, and they become tachypnic. And so you put them back to AC, and you think, okay, I'm never going to get this guy off the vent. This becomes a long-term wean. So what I like to think of for long-term weans is sprint the patient and rest the patient. So put them on pressure support, make them work, right? Put them on pressure support and reduce your pressure support until your RSBI is like 90. Leave them at 90 for as long as they can tolerate. Once their RSBI gets to be above 105, then we need to rest them. So don't put them on SIMV where they have to do half the work still. Put them on AC where the vent's going to take over. Give them a good, adequate tidal volume. Let them rest, okay? And so maybe they did half an hour in the morning. Then you can let them rest another half hour after lunch. And then maybe another half hour in the evening. And then at night, let them sleep, okay? So you're going to and then you're going to make that period of pressure support longer until they can do most of the day. And if they can do most of the day at a low pressure support, then we can consider extubating them. However, often if we get to this point, we're going to think of tracheing them. The benefit of a trach is that you have less resistance. Remember I was talking about if you're intubated, you have a tube from here to here that you have to breathe through that's narrow, right? If you have a trach, it's from here to here. It's shorter than your natural airway, right? So it's actually less resistant, so it's easier to get them off the vent. We let their vocal cords do their job. We don't damage them. It's nicer for their mouth. And it's easier to take them off the vent, see how they do for a while, and put them back on. It's also easier to mobilize the patient. So there are various rules about tracheing. One I like is to anticipate what you think is going to happen. Some people say, oh, it's been 10 days, let's trach tomorrow. But meanwhile, you've been seeing this steady progression. And you think, you know what, I could trach tomorrow, but I might extubate the day after tomorrow. So if after a week, you think in a week, they're still going to be on a ventilator, then you should trach them. If you say at a week, you know what, I think I can extubate in the next few days, then don't, but then 2 days later, reassess. Am I going to be able to extubate in the next few days? If not, reconsider. There are a lot of, as you're traching someone, always remember we need to have a reversible condition, right? We are not able to send someone home on a ventilator here. So if there's some reason we would never be able to get this patient off a vent, a high cervical fracture, diaphragmatic injury, bad neuromuscular disease, traching them makes it easier for them to ventilate, but they are still stuck in our ICU forever. So then you have to think of those ethical things. The other things about long-term weans, make sure they have adequate nutrition. They are exercising. They are doing a lot of work just to breathe, okay? And so they need good nutrition. If anyone has tried to get into shape, they tell you, eat so many carbs and so much protein and so, right? These people, they're trying to build their diaphragm muscle back. And so we need to give them adequate nutrition. We need to make sure their electrolytes are normal. And then other general physical mobility. Get the PTs to do range of motion. If we can get the patient up to sit in a chair to build their core muscles, general strength will help you get them off the vent better. Sawa? All right, questions about weaning or extubation? The steroids, if you're anticipating problems, give them a day before, and then continue for a day or two after, depending how it goes. If the problems just surprise you, start them after extubation, right? So my kid the other day, we gave epinephrine. I talked to the intern or the MO, and they ordered steroids, and I think we gave them for 24 to 48 hours. And you can also reassess. Swali and Guinea? Mm-hmm. Yes. No, you're suctioning more. Normally they say suction what you see. We're suctioning beyond what we can see. We are aggressively burying that yonker into the back of their throat as far back as we can go. All right? You're trying to suction the glottis. All right? Some people do that. They hook up the ambu bag to the vent or and they bag. That's normal, more done in peds. For adults, it's not routinely done that way. Often I just extubate off the vent. A lot of these things can be a little bit place specific. So often, if you're extubating, one of the problems here is we don't have a lot of oxygen flow meters. And so if you're hooking up the ambu bag and you extubate with the ambu bag, then you have to quickly switch over to the oxygen mask and you're fumbling. And so I will often just extubate off the vent and try to use my other flow meter for the oxygen I'm putting them off after. But it's not wrong to do it that way. Swali Ngine? Okay, we are going to completely switch gears right now, okay? So we've been talking about, you know, easy, weaning, getting people off the vent. And now we're going to talk about the crazy vent mode called APRV, okay? So take your head and switch it from easy, this is something I need to understand, to we are talking about a strange vent mode that I'm just going to summarize in the next 10, 15 minutes to give you a little bit of an understanding. And if you walk out saying that mode makes no sense to me, just remember the guy upside down and remember that everything about APRV is upside down, okay? And if you don't fully understand it, neither do 90% of the physicians here, so do not feel bad, okay? But I like this mode, so I will do it to one of your patients at some point. Maybe not one of yours, because anyway. So APRV stands for airway pressure release ventilation. Sometimes the machine calls it bivent, okay? Bivent just means two pressures. And so we can make bivent do APRV settings, and I will explain in a minute. So the machine is going to switch between two pressures. You've got a low pressure and a high pressure. It does this independent of what the patient is doing. All right? It's not waiting for it to trigger. It's not, no, it just says I go at a high pressure, then I go to a low pressure. Then I go to a high pressure, then I go to the low pressure. However, the patient is allowed to breathe on her own at the high pressure. They can breathe on top. So it's like taking a big breath in and then they go down to the low pressure and the patient can breathe. And then we go back up to the high pressure and the patient can breathe. Okay? Make sense? Sort of, kind of. So the benefit of this mode is you can have a high mean airway pressure. And we haven't talked too much about mean airway pressure, but mean airway pressure is the average pressure, okay? So normally, if you have a patient breathing at a rate of 16, they spend, 1 second at the high pressure, if you're on volume control or pressure control, right? But then they're going to spend 2 seconds at your peak. So your average pressure is going to be pretty close to your peak. Are you guys following? Just like mean arterial pressure, when you remember learning about blood pressures. Systole and diastole, we spend more time at the lower pressure, right? So your mean pressure is usually closer to your diastolic pressure. Yes? It is mean airway pressure that really helps with opening the lungs up. All right? I know I told you it was PEEP, because PEEP is the biggest thing that contributes to mean airway pressure. So, but if we switch the ventilator upside down and we spend more time at the high pressure, we're going to do a better job recruiting. Are you confused? Kidogo? So the settings for APRV, you have a P high and a time high and a T high. P high, T high. So the P high is the pressure, the high pressure, and the T high is the time at that pressure. And so normally the P high, you're going to set from 24 to 34. And your T high, not thigh, T high, is going to be 4 to 6 seconds. So you're going to go up to that high pressure and you're going to stay there for 4 seconds. Then you're going to go down to that low pressure. Often we set that low pressure at 0. Sometimes we set it up to 5. Okay? So if you go down to a low pressure of 0, what's going to happen to our lung we recruited, we opened up at that high pressure? What's going to happen? It'll collapse. So you have all decided this mode makes no sense and Annette is crazy, yes? Because if we're going back down to a pressure of 0, we're losing all of our benefit, right? However, this is where APRV and bivent can differ. APRV means that you're taking bivent, and it was called airway pressure release, right? We're going to stay at this pressure high, then we're going to release so quickly that we're only going to let about half the air out. We're not going to let the lungs exhale completely. If our lungs have not exhaled completely, are we de-recruiting? No, we're intentionally air trapping, which I told you last week we want to avoid. But here we're doing it on purpose. So that T low is going to be 0.4 to 0.8 seconds. Sawa? So let me show you what this looks like on our vent. All right, so where'd my mouse go? Mouse. So if we go to our modes, on our vent, it's called bivent. On this vent, they actually call it APRV. All right, and so we can set our time high. Often I like to start this one at 4 seconds, just because I like the number 4. T low, 0.6 seconds. P high, let's start at 25. P low, let's go to 0, and then you set your FiO2, okay? That's it. Confirm. Start ventilation. So notice here, this is our pressure waveform. We are going to a pressure of 25. Where is my alarm? There it is. Okay, they moved it on me. So we are staying at this high pressure for 4 seconds, and then we dump, and we go back down to a pressure of 0. And then we quickly go back up. So this is our flow waveform, right? So you can see the flow is kind of level, and then we start to exhale. And before we finish exhale, the next breath starts. My goal on this mode is I want this next breath to start at about the halfway point. I only want them exhaling halfway. So how can I make them exhale less? What can I change? I can reduce the time we give them to exhale. Okay? So I go to my time low, and I go from 0.6 seconds to 0.5 seconds. And then I look at the waveform. See how it's different? Are we about halfway or bado? Bado, maybe I have to go to 0.45. Halfway? Close enough? Almost. And then we got that, we want to go to 0.42. So, now, if my patient is awake, and I want them to be awake on this mode, okay, they're going to take spontaneous breaths up here. So you're just going to see this kind of jagged flow here as they're taking these spontaneous breaths. But are they going to fill up their lungs kabisa? Or sorry, that's a bad question. Are they going to take a volume of 6 to 8 mils per kilo when they're breathing up here? No, their lung is already full. They're just going to be taking these small little breaths, right? So you're going to see a tidal volume here, 100, 75, 150, and their respiratory rate is going to go up. It's going to be high, 40, 50, because they're taking all these little panting breaths, okay? But intermittently, you're going to see a big volume. I call it a dump volume because we are dumping the air out, okay? So we want this dump volume to be about 8 mils per kilo. So if I tell you this patient is 70 kilos, what do we want the dump volume to be? 560. What is it right now? 740. So how can I make the dump volume less? I can reduce the time low so he exhales even less, right? We can go down to 0.35, see what happens to the volume. See if it changes. Maybe. It stayed about the same. Sometimes it changes, sometimes it doesn't. So what else can I change? Oh, no, there it goes. It dropped. Okay. And now we're 50%, 700. Are we at 560? So what else can I change? Pressure. Am I going to say change my pressure high or my pressure low? So what would I change on my pressure low? P low? Or P high? If we drop our P high, now we're going less high here, right? You can see that difference here. And so we're going to see a drop in volume, right? However, if I have what's interesting about this mode, in other modes we can talk about things for oxygenation and things for ventilation. Sawa? So we can say, in a normal mode, if you are having trouble with oxygenation, what do you do? What do we change? If my sats are low and I'm on AC volume control, what do I change? For oxygenation. FiO2 and PEEP is oxygenation. Ventilation is tidal volume and rate, right? The problem with this mode, and which is why it's complicated, is when to drop my volume, I had to drop my P high, right? What did I say was good about this mode is we're staying at a higher pressure to improve recruitment, right? So by dropping this pressure, I'm losing a little bit out on recruitment. Does that make sense? We talked about mean airway pressure, yes? Let me show you how that works. So here's our mean pressure is 19, okay? So that's on a P high of 20. If I increase my P high to 30, this mean pressure is going to come up. Just wait for it to catch up. Oh, there we go. To 28, okay? So with a mean of 28, I'm getting a lot of recruitment. For fun, let's go to a normal mode, okay? Let's go to volume control. And let's make a PEEP of, let's go big. Let's say 16. Is that a nice high PEEP? Yes? All right, stop beeping. Okay, so now we've switched to normal ventilation, right? Do you see that? And my PEEP, I went big, I went to 16. What do you think my mean airway pressure is? 30? We have a guess of 30. Our peak pressure is 31, right? So our peak pressure right now is comparable to our peak pressure on APRV, right? But our mean right now is the same as our peak. Our mean is, not the same. It's a little bit higher. It's 19. But on APRV, I was able to get it up to 28, okay? So if this patient, let's say they needed a mean of 25 to get them to oxygenate, I would have to take their PEEP all the way up probably to 22, all right? If I've increased my PEEP to 22, what is happening to my peak airway pressure? Wait for it. So now with my PEEP at 22, my peak pressure is going to climb because I'm not getting my volume in, so it's adjusting. Assuming I've said it right. Right, it's slowly climbing, 33, 34. To get that volume in of We wanted 560. We were at 8 per kilo, right? Look how much pressure it's taking us. You see that? And we do have a mean of 25, but our peak pressures are high. So one way to think of APRV is we need these patients. So which type of patient do you think we are going to need APRV for? Bad ARDS, right? Patients who are having trouble oxygenating, okay? The patients who need high PEEP. The problem when you go up on your PEEP is when you ventilate above your PEEP, if you're trying to keep your pressure below 30 and stay above your PEEP, you only have a small amount of space to ventilate. Does that make sense? But when we go to APRV, we are turning it upside down. Our PEEP becomes our normal. Right? Our PEEP becomes the top pressure. And then we release to allow for ventilation. So we keep them high to recruit them, and then we quickly let the volume out. Unaelewa? And so APRV is ventilation upside down. The problem with APRV is sometimes I'm using a long T high. And so right now my rate is only 14. If he's acidotic, how do I increase my rate? I have to reduce my time high, right? And that means we're at that high pressure less time and we're losing the benefits of APRV, okay? The other way I can try clear CO2 is to let him spontaneously breathe and take those little breaths. So it sounds like this mode is uncomfortable, okay? And so it sounds like you should have to paralyze the patients when they're on this mode, but that's not true. Patients can be awake. It feels strange because their lungs get really full, but if you have really sick lungs, I think some of the patients actually like the idea of, finally, my lungs feel like they have air in them again, right? So some patients are more comfortable, and then you just let them take those small breaths, and that helps to bring their CO2 down. Sawa? Are you confused? Like I said, this is a 15-minute overview of this mode. It is a weird mode. It is a confusing mode. But I want you guys to see it kidogo. So when I do it to your patient, you have a little bit of a context of how it's working. Questions? So right now, I am doing this on a patient who has normal lungs, okay? Let's change this patient and let him have ARDS, okay? The problem with ARDS is they have stiff lungs, okay? So with their stiff lungs, what happens to our volume? Right? So you're still, in ARDS, normally we're saying 4 to 6 mil per kilo. I'm targeting about 8 mils per kilo for my dumps, but sometimes it's going to be even less if their lungs are really bad. Because that's what happened to his volumes when I dropped it. So if you have normal lungs, you're going to set your P high really, you're not going to do this on someone with normal lungs. Unless you're experimenting and being strange. And then don't do it because you're inflicting a lot of pressure on them that they don't need. But once we give the patient bad lungs, your volume dropped off. The reason I showed you on someone with normal lungs is because the software does not let you do the flow. Right now, it looks like he's exhaling fully before the next breath. You see that? In real life, I would never get down to a T-low of 0.35 to have it cut off. Normal patients are about 0.5. So I wanted you guys to see that, and the only way I could show you was with normal lungs. Swali ingine? Confused? It's okay to be confused. It is a good mode. So if you are having a patient with bad ARDS and you cannot get them to oxygenate, call me and say, hey, I think we need to try APRV or Bivent. And I can talk you through it or come and help. Because there are some patients which it really helps. And you go from sats of 60 to 90. And then there's some patients you put it on and it makes them worse. The other thing is you're using a lot of pressure, so you have to keep an eye on their blood pressure. Although even though there is a lot of pressure, there are some studies that show decreased problems with blood pressure when you're on this mode, which doesn't make a lot of sense, but I'll take it. Sawa? Swali ingine? All right.